is so important. So this is a case, I'm going to present one case that I saw just 2 days ago. So I got a call from the ER whether they need to cardiovert this patient or not. So he's a 76-year-old male, comes to the ER on the 19th of October with shortness of breath for last 7 days with minimal activity, denied chest pain, palpitation, dizziness, syncope, ankle edema, claudication. He has non-ischemic cardiomyopathy in February of 2015. And by May, ejection fraction improved. In February of 2015, he had AFib with RVR and he was cardioverted, hypertension, and then chronic kidney disease. And he was chronically on carvedilol 6.25 BID. He was not on ACE inhibitor because he has chronic kidney disease. And so ejection fraction, I mentioned in 2015, you can see in the echo, was 20 to 25%. By May of 18th, EF improved, and in echo in December of 2021 showed ejection fraction 55 to 60%. He had a cardiac catheterization, which showed normal coronary arteries in 2015. So, and this is the ECG that I was called with. As you can see, the heart rate is 124. So I need a poll. So I gave only 2 choices. Is it a supraventricular rhythm, which includes sinus tachycardia, atrial flutter, SVT with left bundle branch block, or is it ventricular tachycardia? So let's see what happens.
Rafique bhai, আপনি বললেন যে এই কার্ডিও ভার্সন করবে কি করবে না জিজ্ঞাসা করতেছি ইয়ার না?
Yes.
তো আমি একটা জিনিস বলি যে অনেক সময় আছে যে ভালো যে যদি ডিসাইড করতে না পারো at least প্রেয়ার করো যে প্লিজ পাস আউট, then it is easy.
But okay, so this is good. So majority thought is SVT with underlying left bundle branch block, and some thought ventricular tach. And these are, I mean, I will not blame any side for this. I mean, the question was that but it is so important to make a clinical decision. If it is VT, even though patient's blood pressure is 130, I cannot leave this patient overnight in ventricular tachycardia because patient may crash in the middle of the night. So I had to make a decision based on this ECG. So the rate is 124, and I'm going to go through the algorithm of if white QRS, there is concordance, then it is VT, but there is no concordance. If you look at chest lead, it may look like negative concordance, but there is an R wave. So you cannot have that pattern to call it concordance. So this is not concordance ECG. So it's negative. So based on concordance criteria, this is not VT. Next will be from onset of the R wave to the deepest point of SOB, any precordialate, if it is more than 100 milliseconds, it is VT. So I looked at it and I took V4, V5, and V6. If you look at V5 here, V5, from beginning of QRS to the deepest point of SOB, it is 1 3/4. It's barely 70 milliseconds. And even in V6, it is 80 milliseconds. So it is not over 100 milliseconds. So by that criteria, it did not sound like VT. So is there AV dissociation? Unfortunately, when you have ECG like this, it is very difficult to see AV dissociation because I could not see anything. Rather, I can see that maybe if I call this a P wave, there is a P before QRS, maybe. But I could not clear-cut see any P wave or AV dissociation. So that went out of the window. So then, sorry, is there morphology criteria of VT? And the morphology criteria is, it is a left bundle type, initial R wave in V1, more than 30 milliseconds, or a notch, or this pattern. It did not fulfill that criteria because if you look, let me see if I have the ECG again. This is the ECG. Unfortunately, the ECG has QS pattern in V1, V2, but if you look at V6, even the V6, the initial R is not wide. So based on that, I felt that this was a supraventricular rhythm. So I told them, look, and we got an echo by that time. Ejection fraction now is 15 to 20%. So overnight, we decided that my feeling was that this is—
So the EF dropped now, Rafique bhai? EF has now dropped?
15 to 20%.
So improved, then dropped.
It stayed up from 2015 until December of 2021.
Yeah.
It
So
was
what
normal.
about this lead to 1, 2, 3, 4, 5, 6, 7, 8? What is happening there?
In the beats?
Yes.
Yeah.
Yeah, there are two premature, there are two white
Yes.
QRS beats, and I think those are ventricular beats.
There is some positive.
And Rafique,
Yeah.
sir, I have one question. Was the patient in left bundle branch block
These are
before? Is or
correct
new
to
or
pick,
something?
sir.
Well, okay.
We
So
don't
that's
know.
the part. I don't have that ECG, and I had to
Okay.
make a decision. So I made a clinical decision that this is not VT.
Hmm.
And I told them, look, it is probably flatter. Put the patient on amiodarone, see if it converts. So we started the patient on IV amiodarone, and I looked up the old ECG. This is from 2020.
Mm-hmm.
Normal QRS. There is RSR pattern in lead V1. Nothing remarkable except PSE. But I found another ECG in 2014, exactly like the VT. You see, there is QS pattern and there is a small R. It looked like left bundle. So
more likely as VT.
as supraventricular. Yes.
Supraventricular.
Yes. But look at this. If I did not have this ECG, and if the patient is hemodynamically unstable, then we have to do something more than putting amiodarone. So now I have this ECG same day at 6 p.m., 6:45 p.m. And I have this heart rate is 123. And I have this ECG again. Question is, we have resolved the issue of VT, but I'm still putting it as a choice. I have my 4 choices. What do you think it is? Can I have the poll, please?
Rate is 150. Around
123.
123.
Clinically, Rafique bhai, heart failure আছে?
Oh, yes. Patient by basal
Now 15%.
Yeah.
1/3 of the way of the heart,
Yeah.
hemodynamically stable. And
Heart failure.
Heart failure, yeah, no question.
Yeah.
But this patient never had palpitation, even when the heart rate was 123. So majority say sinus tachycardia with left bundle branch block. I'm glad that they did. Still, some people said VT. 2% said atrial flutter, and then a sinus tachycardia with hyperkalemia. Sinus tachycardia with hyperkalemia, I gave it an option. But please remember, with hyperkalemia, you will not get any sharp signal. Look at V5 and V4. There's a sharp R wave initial. It is unlikely that you will see that in hyperkalemia. If you look at lead 1, it may look sinusoidal, but such a sharp signal in V4, V5, V6, it is unlikely to be hyperkalemia. Question is whether it's sinus tachycardia or atrial flutter with 2-to-1 conduction. So at 3 p.m., the heart rate was 125, at 6:45, 123. And then I'm going to go to the next ECG. This is the ECG next day. Heart rate is 122. And again, again, there is a small P wave here. If you look at, and I appreciate who people who call sinus tach, because it looks biphasic. But what struck me, so the nurses and my nurse practitioner said, Rafique, this is sinus tachycardia. I said, look, something doesn't make sense to me that somebody will stay at a heart rate of 122, 23 for last 24 hours and it is sinus tachycardia, that doesn't make any sense. And this was about before cardioversion. And so what I did, I pulled up telemetry strips. And when I looked at the telemetry strips, I found two strips here, and I have to use a little bit of imagination. Look at here. The RR interval increases here, and there is two waves. And you can say, well, this is artifact. It's my imagination, but this is at a different time, same thing.
And it is a naked eye, Rafique bhai, but it matches, the interval matches.
Yes.
Yes, yes.
So it gave me a little bit more confidence. No, maybe I am right. And so what we did, this is the ECG next morning. Now heart rate is 79. But if you look at, there is negative, the P wave is negative. And I still thought it was flutter with 2-to-1 conduction. And then we cardioverted the patient. This is post-cardioversion ECG. And I didn't give another ECG, which had, when the heart rate goes to 70, patient develops left bundle. So with slow heart rate, it goes to, so this is an interesting case for me because I think we had to make a crucial decision, leave this patient overnight with this heart rate and make the decision not to do any emergent cardioversion. And the question is now that, as I said, echo, ejection fraction now 15 to 20%. I want a poll. What do you want to do? Continue medical management, reevaluate LV function in 3 months, or medical management, implant a defibrillator prior to discharge from hospital? Poll, please.
I think we should have another option.
That's
Well,
what about
yes.
CRTD?
I wanted to put another option, but I did not. And I know what the option is.
Okay.
We'll talk about, we'll discuss that. Can we have the poll, please?
And please participate in the poll, please. There is no, because we want to make sure that we have like 48 participants. If I take the faculty out of this, so at least 30 should be participating, please.
So this is a good split. So I will, there is no D choice, so, but 5 said medical management, reevaluate ejection fraction 3 months, and then 6 said implant a defibrillator. Before I say anything, anybody, any of the faculty, any comment?
So when I interpret anything, Rafique bhai, I also, for some reason, I keep this in mind, the cost and where is the data? Where is the data and where is the cost? Because to continue, this patient has shown nicely that the LV can get better and then LV deteriorates. So we need to figure out what is the cause of this underlying non-ischemic cardiomyopathy. Is tachycardia mediated cardiomyopathy is a possibility? And then what, in that context, what we can do to minimize the cost, because I'm reluctant to go with a defibrillator at this point, device. Before that, I need to try everything else in terms of, and we have nicely shown that there is no sudden cardiac death in this patient. We are not talking about secondary prevention. We are talking about primary prevention, and we have time to sort out that and maybe have a deep dive look.
And I have another comment on that, because more and more data are coming. Because tachycardia-induced cardiomyopathy is one of the things that patient might benefit if he can rhythm control. And as recently we had a lecture in DMC, I showed that one of the case. The thing is that I probably focus on most likely tachycardia-induced cardiomyopathy, whether you can do some permanent solution on this patient. Whether since it's a flutter, there's a possibility for ablation. So one thing, definitely need to cardiovert the patient to bring him back to normal rhythm. Then second question comes, so they need to, at the same time, where they could potentially ablate the patient. Third, what to do with the left bundle branch block, whether there is a dysynchrony going on, or they need to synchronize that with CRT device? That's the third question we have. So we have to keep in mind that we like to keep the patient in normal sinus rhythm as much as possible, because in all the AFib, A-flutter patient, this subgroup of patients, the benefit with the rhythm control, the benefit compared to other group.
Anybody else? Any other faculty, any comment?
Kamrul, can you connect Azizul Hasan Khandaka, raised hand?
Yes, sir.
I will make a comment, sir.
Yes.
Tachycardia is very unlikely to deteriorate that much in terms of ejection fraction. We should remember that. But
What was the comment?
sir, any person with persistent sinus tachycardia is unlikely to deteriorate in LV function that much.
Absolutely, absolutely.
And whenever you see the LV function deteriorating that fast, it must be some sort of cardiac tachycardia, the malignant tachycardia. Atrial flutter is particularly important.
Okay, so let me answer this question. Hafiz actually alluded to it very nicely. Let's make an assumption that this patient actually a new onset cardiomyopathy, because in December of 2021, ejection fraction was normal. So when I get a new onset cardiomyopathy, I have to treat them medically for 3 months. And of course, I have to rule out ischemia if I need to, if I clinically feel it's important. And if after 3 months of medical treatment and management of ischemia, if there is ischemia means coronary disease, then ejection fraction less than 35%, then we put an ICD in for primary prevention of sudden cardiac death. So implanting defibrillator in this patient is a little premature. Second, this patient in 2015 presented with AFib with RVR and had no palpitation. And this time also with a heart rate of 124, he complains, it is possible. These kind of patients, what they do, they stay in a heart rate of 120, 130, 140, 150 without any symptom for months and develops cardiomyopathy. And it will improve, hopefully. So the hard question is whether I need to do an ablation on this patient or not. I am not going to do an ablation on this patient. Why? Look at this patient. This patient had AFib in 2015, and he did fine for 7 years without any antiarrhythmic medication. As a matter of fact, after cardioversion, I've stopped his amiodarone. So I'm going to send this patient out on medical management. Now, he's still in the hospital. Tomorrow, I'm going to repeat an echo. If I find that ejection fraction is more than 35%, then fantastic, because I don't want to put him on a live vest. If it is ejection fraction is less than 35 tomorrow morning, I'm going to put a live vest in and discharge him home on medical management. And I'm hoping that within the next few months, his ejection fraction will get better. And then I'll just continue following it. The question is whether I am going to do a stress test or not. Probably I'll do a stress test, but I'm not doing a nuclear stress test just to make sure things are all right. That I'll do as an outpatient. Hafiz, any other comment on this? Hafiz? I think Hafiz is disconnected.
Rafique sir, one question I have.
Yes.
We definitely need to do cardioversion in our resources that you have. If the patient is in Bangladesh, then concerned about what kind of medical antiarrhythmic or what you're going to choose. I know you're taking off the amiodarone.
Yes.
Because there's likelihood the patient might go back.
Sure. Yes. No question. Yes. But if you look at this patient, for 7 years, he did fantastic without any antiarrhythmic medicine. I am not going to put him on antiarrhythmic. What I'm going to do, I'm going to educate him how to check his pulse at home, either manually or with a blood pressure machine. And I will tell them, look, if at any time you find that your heart rate is constantly over 100 beats per minute, tell us. And if I find that within the next 2 to 3 months or within 6 months, he has recurrent atrial flutter or fibrillation, then I will consider either ablation or antiarrhythmic treatment, but not before that.
রফিক ভাই আপনি এখনই কেন অ্যাবলেট করবেন না?
খন্দকারের হাত তুলেছে, তাকে ঢুকতে দাও।
কি বলতে
Question
হাফিজ?
করতে চায়।
বলতেছি আপনি এখনই কেন অ্যাবলেট করবেন না?
এখন করব না কেন? Because this patient did extremely well for 7 years without any intervention for the arrhythmia. And if this patient stays without, first of all, we do not know what type of flutter it was. It is the atypical flutter, so we don't know the focus. Sometimes we do it if it is very typical flutter and frequent recurrence, but it is not typical flutter, it's atypical flutter, and I have to wait for recurrence if I am considering for ablation.
আচ্ছা, কে যেন হাত তুলেছিল, ডাক্তার আইজুল হাসান, তাকে একটু করতে দিবা, কথা বলতে দাও না।
স্যার অ্যালাউ করা আছে স্যার।
ডক্টর আইজুল, তুমি আনমিউট করে করো, কথা বলো। ডক্টর আইজুল হাসান, হাত হ্যান্ড রেজ করা।
দুই তিনটা কোশ্চেন আছে স্যার এখানে।
হ্যাঁ বলো।
না কোশ্চেন মানে কোশ্চেন করেছে কেউ কেউ, বিশাল চেষ্টা করেছে, অ্যানোনিমাস একজন করেছে। ডক্টর বিশাল কোশ্চেন করছে, হোয়াট ডু ইউ ডু অ্যাবাউট দ্য অ্যান্টিকোগুলেশন ইন দিস কেস স্যার?
It needs to be anticoagulated, yeah.
অ্যান্টিকোগুলেশন
When the patient has
আদিত ভাই বলো।
when the patient has LV dysfunction, that's a different entity apart from we call Chats-VAS score that we consider normally for anticoagulation. If the EF is low, there's higher and left atrial dimension is high, then this patient needs to be anticoagulated, because then we don't look for the Chats-VAS score nowadays, because they have high propensity of blood clot formation and stroke. So this patient needs to be anticoagulated. Definitely, depending on the choice, what kind of choice you have, the kidney function, and NOAC, if the patient is, eligible for that and the patient can afford that, then you can start on Epic-7 or Xarelto. If Xarelto, if the patient's kidney function at least 30%, clearance is more than 30, you can safely do that. But Epic-7 definitely can do it. Other choice is always warfarin, but difficult to manage in that situation. Yeah, patient needs to be anticoagulated with that low EF.
On the issue of anticoagulation, a couple of things I think important, because in the rheumatic mitral valve disease and atrial flutter, atrial fibrillation, they are off the chart. So we need to use anticoagulation in those patients. And also in hypertrophic cardiomyopathy and AFib and thyrotoxicosis, because these are not the patients, historically, they are not included in the SPAF, SPINAF, and all these atrial fibrillation trials. But it is true, and it still holds true. If the Chats-VAS score is high, then in otherwise non-valvular AFib, the risk also goes higher with the stroke occurrence. So in this case, Chats-VAS is already high, we know. So I would be more inclined to give anticoagulation.
So I'm sorry, I forgot to mention in my note that patient was chronically on warfarin because of high Chats-VAS score. So that's why we could cardiovert him without TE, because if he was not on anticoagulation, we had to do a TE cardioversion. We just did regular cardioversion because he was therapeutic INR for many months.
I do TE regardless, because on Coumadin particularly, I don't know how much INR control, because therapeutic INR on Coumadin, if you look at the studies, they were really not so good. So I usually, to me, it's like an additional step, but I usually do TE cardioversion.
Hafiz, this is the part of American medicine that I'll tell you what, everybody talks about INR. This patient, INR, of course, was therapeutic. Last 6 months over 3, around 3. When they want to sell this new drug, they talk about non-compliance with warfarin, blah, blah, blah. But nobody talks about non-compliance with NOACs. People are on Eliquis, they're not taking it. They're missing dose. That's the problem part. But you
But
are
the
absolutely right.
non-compliance, the biggest problem, particularly even in the city of Las Vegas with the Coumadin, we have hardly any religious Coumadin clinic. I mean, this is practically becoming a problem
Yes.
because Coumadin clinic doesn't make money and nobody does it. So now we are switching more and more to DOAC because of that.
Yes. So, I mean, but as Hafiz pointed out, that if there is any doubt about the compliance, about iron, we always do TE, cardioversion, because it makes it safer for the patient. More so in patients who have history of stroke and other comorbidity conditions, TE cardioversion is really a good option. Thank you.
Excellent case, Rafique bhai.
Thank you.
Sir, my observation that in our country, patient with LV aneurysm, post-MI, or DCM and dilated heart, not many people are getting anticoagulation. They are putting 2 antiplatelet, not doing angio. Most of the time you will find that coronaries are normal, but not putting any anticoagulation.
Yeah.
Well, that is a problem. I mean, data is very clear for stroke prevention in this group, high-risk group for AFib. Those drugs doesn't really do much.
Rafique bhai, আমি একটু কিউরিয়াস, আপনি হার্ট ফেলিয়ার মেডিসিন সব একসাথে থ্রো করছেন এখানে, লাইক এন্ট্রেস্টো and carvedilol and aldactone,
No.
inhibitors.
This is the problem, Hafiz. This patient was chronically on carvedilol 6.25 BID. He has chronic kidney disease.
And
So
has amyloid.
he was not on ACE inhibitor or Entresto because of that. So, but talking about chronic kidney disease for the audience, the presence of chronic kidney does not say that you cannot start ACE inhibitor. You have to look at the GFR, you have to look at the creatinine level, and you start the medicine and then reevaluate kidney function to see if it gets any worse. So I'm going
and
to
also find a new nephrologist if you can, he will be willing to give it, because they don't, sometimes it could be chicken or the egg. It could be prerenal cause of heart failure giving the creatinine high, and that exactly you need to do. And also, if there is no significant proteinuria, no cast, no glomerular disease, usually they tolerate very well and they actually benefit. And similarly, in a diabetic patients, when there is no intrinsic renal disease, SGLT inhibitors and these may actually be protective for the kidney and delaying dialysis. So
Yes.
we are denying this very patient that we should be giving.
Sure, no question.
And first thing, the patient has been on amlodipine, that should be discontinued.
Hafiz, thank you. আমি একটু মাঝে মধ্যে follow. Aziz sir.
And patient আমার যতদূর মনে পড়ছে যে patient amlodipine ছিল আর কি, হ্যাঁ, carvedilol and amlodipine. So if question right now, definitely need to have a vasodilator. Amlodipine should be discontinued. You have any question about creatinine, you don't want to give anything, put an at least hydralazine and isosorbide long acting. But in my understanding, that sometimes we can start, actually can safely start the ACE inhibitor and monitor that, as Dr. Hassan mentioned. And if the creatinine doesn't rise more than 15-20%, you should continue that, even with the chronic renal disease. They ultimately would benefit.
Yes.
All right, thank you.
Rafique sir, আমি একটু অ্যাড করতে চাই স্যার।
Definitely, please.
এটা হচ্ছে স্যার যে যদি পেশেন্টের ক্রনিক ডিজিজ থাকে স্টেজ 3 পর্যন্ত এস ইনহিবিটর বা এন্টাস্টো দেওয়ার কোনো কন্ট্রাইন্ডিকেশন নেই, উই ক্যান পুট ইট ইজিলি। বাট আমাদেরকে যেটা ফলো আপ করতে হবে যে ক্রিয়েটিনিন লেভেলটা বাড়ছে কিনা, 50% যদি বাড়ে স্টপ করব, যদি 30% বাড়ে আমরা এটাকে হাফ ডোজে কন্টিনিউ করার চেষ্টা করব। সেটা জাস্ট শুধু একটু ক্রিটিক্যাল ফলো আপ করলে হবে, এটাই হচ্ছে রিকমেন্ডেশন ক্রনিক কিডনি ডিজিজ ফ্রম দ্য পারসপেক্টিভ।
ইন্টারেস্ট বাংলাদেশে কি নামে এবং দাম কত?
এন্ট্রেস্টো পাওয়া যায় বাংলাদেশে 4টা
বাংলাদেশে এন্ট্রেস্টো নামে পাওয়া যায়।
এন্ট্রেস্টো নামে পাওয়া যায়।
হাফিজ ভাই,
আর হাফিজ স্যার, আমি আপনার সাথে একমত এই ব্যাপারে। আমিও কিছু পেশেন্টের SGLT2 AGLT2 এবং এন্টেস্টো শুরু করে দেখছি একজন নেফ্রোলজিস্ট হয়তো বন্ধ করে দিচ্ছে, তখন আমি ইউজুয়ালি পেশেন্টকে আরেকজনের কাছে পাঠাই। দেখি আমি যতবারই দেই না কেন, নেফ্রোলজিস্ট যখন বলে এটা খাওয়া যাবে না, রোগী ওটা বন্ধ করে দেয়।
Exactly. So you need to find a new nephrologist.
বাংলাদেশে অরিজিনাল ইন্টারেস্টের দাম কম। বাংলাদেশে হলো $2.5, আমেরিকায় তো হলো 200 মিলিগ্রাম, আমেরিকায় বোধহয় $11, তাই না?
Right.
বাংলাদেশে এটা অনেক কম।
আমাদের দেশে কিন্তু
অরিজিনাল
অনেক কম।
ওরা এটা স্পেশালি বাংলাদেশের জন্য।
যদি দেশি কোম্পানি হয় তাতে আরো কম, যদি ইন্টারেস্ট হয় একটু বেশি, কিন্তু দেশি কোম্পানিতে একদম কম। আর অশোক দা, আপনাকে যেটা করতে হবে, এটা ফ্রিকুয়েন্টলি আমরা পাচ্ছি আর কি, যে নেফ্রোলজিস্টরা অলওয়েজ এটা করছে। তো ওদের সাথে একটু ভালো রিলেশন তৈরি করেন, ওদেরকে একটু আপনার যে গাইডলাইন গুলো একটু মাঝে মাঝে হোয়াটসঅ্যাপে পাঠান, তাইলে দেখবেন একটু কাজ হয়।
একটা মিটিং করলে হয় যে কার্ডিও রেনাল এবং হার্ট ফেলিওর, কিডনি ডিজিজ, একটা ওদেরকে আমাদের এক পেজে নিয়ে আসতে হবে। কারণ অনেস্টলি আফটার হার্ট আই লাভ the organ most is kidney.
So this is the problem. This problem not only in Bangladesh exists in America. That
Absolutely.
2 issues. You cannot start carvedilol because blood pressure is low. That's one fallacy. You cannot start ACE inhibitor because creatinine is high. Both are wrong notions. We can always try these medicines and then follow. The other problem is when one doctor says, look, you should never be on this medicine, it's going to kill you. It is very, very difficult to start that medicine. But we can always sit down with the patient that, look, I'm going to put you on the medicine. I'm going to check your kidney function because your kidney function may be secondary to heart problem, that your kidney function is abnormal. And once you can improve it, kidney function will improve. And that is where the dilemma is. And of course, as Hafiz mentioned, that it's continuing education. I mean, we grew up at a generation when if I put beta blocker in heart failure patient, I would never pass MBBS. And look at where we are today, that we are giving beta blocker to patients with low ejection fraction. My professor would have killed me if I gave beta blocker to a heart failure patient. Thank you. I think we can close today.
Yes, sir. Thank you very much, sir. Actually, very excellent presentation. Abdullah Jamil, congratulations. Thank you very much for your nice collection and beautiful presentation. Finally, excellent case by Rafique sir. Sir, our next session on the 6th November on pediatric ECG. Naharuma Haidar. Naharuma, you are here? Dr. Naharuma?
Ji sir. Assalamu alaikum sir. Achi sir.
So Naharuma, we are waiting for your talks. That is on the 6th November.
So 6th November to first Sunday হয় মনে হয় স্যার মাসে। ওটাতে হবে স্যার?
That is আচ্ছা, I will let you know the dates exactly.
আচ্ছা স্যার, 6th November হলে আমি পারবো স্যার।
Our next session by the Dr. Naharuma Chaudhary sir, pediatric ECG sir.
Okay, sure. See you then. Goodbye.
So Abdullah Chaudhary, I am requesting you to wrap up the session, today's session.
Today's session is important in the context that, as Rafique sir was saying, if you know what is normal, then you can actually identify abnormal much better. That's the point. You do not put the patient through unnecessary anxiety or investigation or medication if you know that it's a normal variation. Jamil bhai, I would have been happy if you have put that the small Q in inferior leads that disappear with deep inspiration. Repeat the ECG with deep inspiration, the Q will get well. I sometimes tell the patient, আপনাকে আমি এক্ষুনি ভালো করে দিচ্ছি, আপনার এটা দেখেন যে হার্ট অ্যাটাক যেটা বলছিল এটা চলে যাবে, বলে ওকে ওটা করে দেখাই যে এই দেখেন এটা চলে গেছে, it's normal. So that thing should be put in there as a normal variation. That will be much better. And today we really enjoyed the whole thing. Thank you, Jamil bhai. Thank you for an excellent collection of normal variations.
Any comments?
Ahmed, would you make some comment, please?
No, thank you. I enjoy a lot of things from Jamil bhai lectures, and also Hafiz bhai and Rafique sir and Wadud, and also Athar Ali sir's comment. ECG is the basic thing of cardiology. You mind it. Always when I take a lecture, I told the student the ECG is the cornerstone of the all tidbits should be known. So I think it's a very good arrangement by Wadud and Atar Ali sir. Thank you. Good night to all.
আমি একটা কমেন্ট করতে চাই, সেটা হচ্ছে কি যে এই ইসিজি বেসিক্স এন্ড বিয়ন্ড এইটাতে ওয়াদুদ, আতার ভাই এবং রফিক ভাই আমাকে ইনক্লুড করছে, এবং আমি দেখলাম যে এইটা ইনক্লুড হওয়ার পরে আমি এই ইসিজি এখন দিয়ে শুরু করি রেসিডেন্টদেরকে। আমার মানে টিচিং এ আমার পপুলারিটি এখন স্কাই রকেট এই ইসিজি দিয়ে শুরু করা হয়েছে। সো দিস ইজ এ থ্যাংক ইউ অল।
Actually, it's এত important, এত interesting. It can tell you a story.
Orun Maski.
Orun is here.